have one similar session, though not on Salesforce. This is related to mobile application, where our colleague Amritansh is going to share his experience, working on a mobile app, building structured digital systems for a national scale mental health service. So this is going to be a healthcare app that he's going to discuss about, and he will share his experience working on this particular project, and what are the objectives of the project, what were the challenges that he faced, what was the problem statement, and then what solution was provided, and how the scale of the whole project, and how they went about solving this, and what were the outcomes at the end of it, right? So I'm sure all of us will definitely gain a lot of insights out of this presentation from Amritansh, and at the end of the session, I'm sure if there are any questions, please feel free to ask. And for all the people who are watching this on YouTube, as part of an initiative from Utilitarian Labs, we are hosting all these things on our YouTube site, so that it's available for not only people within this organization. This knowledge is available for people outside the utilitarian ecosystem, so that it is useful and helpful to all techies. Thank you, and over to you, Amritansh.
Thank you, sir. Very good morning, everyone. Thank you, Kiran sir, for that lovely warm introduction, and thank you everyone for your presence here. So today I'll be talking about, my topic here is building a structured digital system for national scale mental health service. So this was basically, I'll just give you an overview. This is about my past project here, before where I was working at, and to avoid any kind of confidentiality in the implementation side, so I would be not using those terminologies here. I'll be just keeping this presentation very plain and simple, and at a very high level here. So yeah. In mental health care, the trained professionals, they are the ones who take the final judgment on a clinical decision perspective, or whether to have this person prescribing a particular medicine or not, or whether to escalate this person to a further escalation or not. So in that way, we have instead, so digital systems where we have initially thought about of implementing it. So we thought, yeah, why should digital system be the one who should be, why should be a digital system? Sorry, I'm so sorry. Can we restart if possible? It's okay, right? Having some trouble. Okay, I'll restart. Sorry, once again. So today I'll be speaking about how structured digital systems are designed to support the health service at a national scale level. So this discussion is actually based on my experience working with the Public Digital Health Initiative, where I was part of this program called Telemanas. That's the only name that I can take right now here. And yeah, so through this session, I'll take you through what the system designs are and why are they necessary to implement such projects at a high national level scale, and find some key learnings from my building in that ecosystem, and what different layers of care, like we had different care layers given in the project there. So what were those, including the mobile app that we had created for the citizen to access the mental health content for them. So let's introduce with our first slide here, why structured mental health systems are needed. So as you can see the bullet points here, I'll just go through all of them in general. The rising mental health awareness. So the mental health awareness is overall significantly increasing among the people, and more people and more individuals are actively seeking help towards seeking the support of whether they are suffering from anxiety, stress and depressions. So in the problem issue that we have here is that we even discovered during our implementation of the project that there is very limited availability of the sources. The sources, we call it as trained professionals. They are very limited across the nation. So, and especially outside of the urban areas. So you can talk about the rural areas, right? So there may not be a lot of mental health establishments, not even trained professionals, due to the certain factors with the rural areas that we have. For example, some low connectivity, or you can talk about less technology, and further etc. there. So which is why we had this problem statement discovered कि yeah, rather than having this mental health programs offline across the nation, why not extend that into a digital aspect of it, make it a digital aspect and make it more accessible for the people who cannot access this by going to the offline establishments such as hospitals or facilities. And one more issue was, yeah, so this was to this point here, which connects to this point here. So which is why, yeah, due to the limited availability of these resources there, this gap between the demand and the availability rose to a high level. So demand as in the need to speak to a counselor or a mental health professional to talk about what they are going through, and the availability being the trained professionals, which is very less. And there's also a stigma that runs around in the society, which kind of discourages the individuals to go to the mental health hospitals right away, and then yeah, talk about their problems, talk about their issues. So that's another one main problem. Can I go back here? Laptop is fine.
Yes,
Achha, yes, it's fine. Yeah. So yeah, ultimately we thought about, yeah, it was a much need for the mental health service to go at a national level scale in terms of the digital aspect, which is why, and you may agree or not agree, but I think we can state this fact that for every system, a defined structure is needed overall, because to scale it to a national level or any other at the maximum capacity level. So coming to the next one, we have the operational challenges at the national scale that we have. So whichever any service in general, if we talk about, if it goes to a very high level, we expect the demand to also increase rapidly and at a very unpredictable rate. Yeah. More importantly, the continuity of care. So the continuity of care, which emphasizes on a patient who has just received a consultation, they would also come back and return again to that same platform again and talk about whatever issues that they had further. So that continuity of care is also important to make sure that it's present in the system. And more importantly, the crisis sensitive cases, where so this is from a live example that I talk about, where we had a lot of cases where we saw patients who were speaking about the emotional level of the stress and the emotional level at a very high quotient that they had, along with having the suicidal ideations in their thought processes. So, which is why we had these trained professionals train them in such a way that they assess those by making a proper consultation and yeah, take the next course of action accordingly. Next, so this is about the multi-tier support structure we have here. So our program, which basically was divided into two tiers. Tier 1 being the frontline counselors, who were going to be the initial people, trained professionals who were going to be taking these calls, and tier 2 being the professional mental health professionals, who were the doctors, psychiatrists, psychologists, and psychiatric nurses, and so on. So this is why we had divided this, which I'll explain to you the purpose behind this dividing into the two tier. And finally, being the governance oversights. Yeah, so we had the leaderships and the apex bodies who needed insights and about the data that was being collected at the national level, and accordingly deploy and allocate the resources that they have to the regions of the nation accordingly and responsibly. So these were some operational challenges. Coming to the next slide, we have what a structured digital system provides. I mean, to answer this question, we clearly know that it clarifies across, it creates a clarity across a service workflow here. So suppose now we talk about a defined case life. So I'll take an example of our case life cycle here. So in our case, we had the case life cycle where the so the clear progression from intake to course. So as long as a case life cycle is properly defined, so the conversations that we're having between these patients and these trained professionals, they were predictable. They became predictable because we already had this defined case life cycle ready with us. So which kind of reduced the ambiguity and improved more coordination with the person who's using the application for noting this all the information down and the user. Next comes the standardized documentation. So basically having a uniform documentation created for these users to enter the e-health records in the system. And so that a proper unified documentation allowed them to fast track the process of taking as many calls as possible for them, for every patient, because of course it's a national level project there and you expect a lot of calls to be on the queue right there. So to fast track this process for counselors, so we had this a proper structured application where all the fields are defined for them and what nodes that they have to enter. Next, we have the structured referral pathways. So this structured referral pathways is basically talking about if a call that's needed to get further escalated from tier 1 to tier 2, like I talked about, right? Tier 1 being the counselors. So counselors, what they do is they do the basic consultation from their end. Yeah. They're not doctors, but they're just trained consultant, trained professionals who can assess what the patient is going through and what emotional and stress levels that they're having. Some point out some problem indicators in the patient side. So if they feel that they need to escalate this call because this patient needs further intervention from a proper doctor, they would go on and create a referral to that doctor from the same system. This is how we had the system structured to create referrals from tier 1 to tier 2 users. Then role-based access control. That's of course that's needed to be there since counselors being the tier 1 professionals there. And tier 2 being the doctors. So the amount of data that the tier 2 doctors were entering was far more than what the counselors, the tier 1 were entering. So which is why we had to ensure that the data that was being entered by the doctors, tier 2 doctors, was not available to the tier 1 counselors there. Then a centralized dashboard is of course we needed to be there for the operation and the governance visibility. And as I mentioned before, to help the apex bodies and the leadership to allocate their resources responsibly, because since they also have a limited budget as being a government project. Coming to the next slide. So this is an overview of the case life cycle here. I'll just take you through how the life cycle of the simple case works here. As I previously explained, but this is a way more detailed one. So we start with the intake and registration. A patient calls to the helpline and then the counselor is the person who takes that call first, because them being the tier 1 professionals there. They take the call, they capture some presenting concerns and demographics, and those are the basic context that needs to be captured, of course, to register that patient into that system. Then next comes the assessment part, where the counselor evaluates the emotional quotient and like I mentioned again some risk indicators that the patient is going through and their psychological conditions. So this is a call between a counselor and the patient that's still going on here. Then next one, after this, where if the counselor again feels if it's needed to make an escalation to a professional doctor there, so they will go on and make that referral through the system and escalate the call. Later on, the fourth stage being the follow-up engagement. So whoever took the call, whoever it was transitioned to from counselor, whoever it could be that counselor was the one who took the call by himself or herself, and then they handled the call accordingly. They did not need more escalation. So whoever took the call here, they had a consent taken from the patient asking, do you need a follow-up call from us to check up on you, whether you need a further checking up on you, and so reasons. So if the consent was given yes from the patient, they would go on and create a callback from the system for the patient there. Next being the closure part. So here the system would ensure that all the data that is needed to be captured for the system to save and store the record was performed here with all the validations that were needed, capturing all the call details, capturing all the callback details, or capturing any e-health records, all the aspects. So this would come down to the closure bit. So this is how the life cycle of a user who's calling for the first time works. Next is designing for KLAs, frontline to specialists. So I've just used very general terms here, but as I speak, I'm letting you guys know what these terms are. So KLAs are basically the interfaces that we designed for the counselors and the mental health professionals here. And yeah, so I'll just take you through what, as I already explained it to you, what the interfaces look like and what the referrals look like. There was, yeah, this is all mainly the points that have been covered. I would like to add one more point here stating that, so it was not, so as and when the program went ahead, since it's very recently launched, as and when the program went ahead, the more aspects to it came into, where the offline sectors that were already present, offline establishments that were already present in the nation, they were also being slowly and gradually included into this one ecosystem, that is one national ecosystem, one digital ecosystem you could say, yeah, for mental health. So yeah, I would not name it, but I would just say, yeah, so they were, these two being the main two tiers of the main program, and including another users, which would call them psychiatrists only, but they will be sitting on their own hospitals or own clinics that they have. Yeah. So we also created modules for them. So so overall, gradually we had the referrals that needed to be that referrals that we talked about before, right? Either transferring it from counselor to MHPs. So those referrals also were also possible to create from the counselor module to the doctors, psychiatrist modules who are sitting in their own offices. Yeah, this is one of the main important topic which I want to talk about, the extending mental health services to the citizen, which is nothing but the mobile app that we had created to give the citizen overview, and not just an overview, an educational content along with activities, some self-assessment, some DIY activities for them, and what else were they? That's just basic things that were there for them. So yeah, so coming from the development side, yeah, so we needed to ensure that all these content, and when we started with the development side, we ensured that to make this app scalable, we had to ensure that we cover all the aspects that were needed. One being the multilingual aspect. So not every person, not everyone is comfortable reading English or Hindi right away. So we needed to ensure that if we are loading all the content into a CMS tool that we had taken up, so we ensure that it remains multilingual. And then we had some chatbot assisted navigation that we had started, which was basically a rule based chatbot that we had. Overall, it was going to be developed into later having user giving their own prompts, giving their own text, and later the AI tool helping the AI tool giving the response accordingly. But yeah, so this was the main key aspects, and yeah, one of the main key thing was a dialect helpline integration. So with the educational content that were there, mostly had talk about illness, mental stress. So there were a lot of articles there, about 20-30 plus articles which are there, and at the end of the page of every article, we gave them a call CTA button basically to have the user directly reach out to the helpline number, so that if they're going through the article and if they're feeling, okay, I've gone through so and so thing, maybe I need to consult more and understand better. So we had that CTA button enabled in the app also wherever it was needed. And yeah, these were the other aspects: the interactive well-being tools, multilingual access, and centralized content governance. As we had talked about the CMS tool here. What major? So here we had, yeah, one more thing where it was also possible for users to give their feedback. I mean, yeah, we also had this rate functionality where users could also go ahead and rate the services of the or the system of the program that was being run for both app and for both the system. That was another key aspect of it. So coming to the implementation realities here. So yeah, these are the few major things which we had, which especially I and along with my team had to take care of. So the multi-stakeholder coordination. So the stakeholders mostly being the operational teams, the clinical teams, and then the technical teams, and also your development teams and all. So to align them together, because every team had their own view towards the implementation side. So to have them all aligned together, we ensured that we had the clarity of responsibilities conveyed to every one of them, and I think yeah, the clarity of responsibilities and what else? I'll just move on to the next one. So policy evolution management. Yeah, this was of course one of the major thing. The project being a government one. So we had the policies and the guidelines almost evolving or almost changing every now and then in every quarter. So which is why we ensured that work, our work base that was designed, it was adaptable enough to all these policy and the guideline changes that were coming from the stakeholders. And training at the national scale was a major aspect, since all these resources, counselors and mental health professionals, of course, would definitely require training of such applications. These were conducted at a national level with each state. In every state, we had a city where we would go and in a city like, just for example, I was privileged to go and give trainings to the doctors and the counselors from NIMHANS. So we had about 100 and 150 users sitting there. So we gave a proper end-to-end flow and the training that was needed from them. And finally, yeah, the data privacy and compliance controls is of course that's being needed. And finally, these are final of my key learnings which I found during my project there. The process clarity before technology decisions is of course that's major thing. The operational workflows was needed to be clarified before making any technological decisions there. Otherwise, the system would go haphazard. So, strong workflows are the foundations of the scalable system. Human-centered decision support. So, we thought the technology, the system that we are going to be building, it should not be replacing the professionals who are going to be taking the calls, but they should be assisting them and making it more, what do you say, supportive, collaborative, and more control, rather than not replacing them. Then standardization enables national scalability. Of course, that's we talked about before. So standardizing the content or the content, the documentation, what all these users are going to be doing in the application there, keeping a uniform mechanism. So it strengthens the coordination and reporting from there into. And governance visibility drives improvement, of course. So the leaderships, when they see all these and when they get their inputs, when they find out, yeah, okay, these are all the trending things and these are all the trends we see in so and so regions. So we get inputs from them and realize, yeah, okay, we need to improve in so and so sector. We need to have more and more training to be given to so and so regions. So this is how the governance visibility drives more improvement to the project there. And ecosystem thinking over feature thinking is a universal thing. So this was a major project thing which I shared with you all guys. Thank you so much. And now the platform is open for you to ask any questions.
I'd like to speak anything on the technology stack used, if you are aware of it. The backend.
Backend aspects, sir, I am not fully aware of it, which is why I won't be able to answer it right now, but I'll get back to you. Okay. Yes. Yeah.
I have a question.
Hmm.
So, if we want to talk about the entire process from the user's point of view, what exactly it is going to do?
Who is your user?
Goes on to register on this application. He goes on to emphasize that he's not kind of mentally well, right? So, what is the very process flow that is actually being followed after that?
Okay. So there's no specific registration here. The user just right away calls to this helpline number here, right? And like I mentioned, the tier 1 professionals being the counselor, they are the first person whom these patients speak out to right away. And then the assessment is being done from the counselor side for this patient, of what he is going through, what he is suffering from. If needed, he will go and escalate the call to the trained professionals, which are these doctors here, tier 2, the psychiatrists and psychologists there.
So the very tier 1 जो professional है, he's actually doing the very psychoanalysis, right?
Yeah.
He's taking all the records, and at the same time he's trying to analyze what is the very health status of it.
Exactly.
If it is complicated, then he's escalating it to the one who's having
more experience than
more competent to address the problem. And also certain critical states where immediately it needs to be addressed. Patient is in a very dire situation.
Exactly. So again, if we are getting back to that point, let us suppose that the severity of the mental health is kind of even more.
Yeah.
Okay. And then the branch kind of it divides from psychology to psychiatry. Because when we are talking about psychology, it is mostly healing the other person through words.
Yeah.
It's not about medication.
Yeah.
Right? And then psychiatry actually comes into the very existence. So
Yep.
how exactly it is getting divided? Even then there are certain branches that are being opened up.
Fair question. So yeah, like you mentioned, we have these tier 2 doctors for each roles that they are there, be it for psychology, be it for psychiatry, or be it senior consultant psychiatry, or be it a junior consultant psychiatry. So what our system used to do was, if the counselor felt if that record needs to go to certain so-and-so psychology, for example, so our system had that provision where they would select that particular user that I want to transfer to make a referral to. They would go on and select with the role being displayed for them that this is the person, Dr. So-and-so, with role mentioned below it, and they would go on and click on that. That will go and transfer the call to that doctor there.
So, what are the rubrics that we are actually following, that we are able to distinguish between these two people, the different needs? That's what I'm trying to say.
I mean, it's up to the counselors for them to understand what basic training, which from the medical aspect, I may not be able to answer that question, because these trainings for how and when the call that needs to be transferred and what kind of call that needs to be transferred, those are all done by the doctors itself. But yeah, like I mentioned there, our system had that provision for these users to make that call transfer to a particular person based on the diagnosis that's being done by this counselor here.
It's like a regular routine medical case. You go to a hospital, for example, you meet a physician there. The physician sees some abnormalities in your diagnosis, and then he says, okay, I think this could be a nephrology case, kidney case, let me refer you to a nephrologist. You could be right, you could be wrong. Nephrology then goes through entire history and he says, okay, this is not a nephrology, this is more of a cardiology case. So he'll refer to a cardiologist. Probably similar kind of system here. The counselors are trained to take a call whether this should be a psychiatric case or this could be a psychologist case, and based on their experience and what they see on the record from the patient, they will direct it to the concerned person.
Why the skepticism was there was because we are not physically evaluating the very patient.
Correct.
It's
like virtual. It was telemedicine also the same thing, right? If you look at telemedicine also, most of it is on virtual. Even a patient, he's only uploading his records or he's only talking to a doctor, and then probably the doctor is prescribing some tests or those things. Same thing here also, virtual thing. based on the counselors who are trained. They are not normal people. They are not telecallers. They are trained counselors. So they take the call whether it should be referred to a psychologist or a psychiatrist, and then they pass the call. That person then will decide whether it is his call or it should be sent to a different person. A psychiatrist might think, okay, this is not a case of psychiatry, it should be sent to a psychologist where counseling is done. Right? Then he might redirect the call back to the counselor who will then send it back to. So that error is possible, but mostly based on the training that they have, probably they should be doing a right job. But of course,
I was actually assuming was that let us suppose that there are certain findings, the key findings that the like the most senior consulted psychologist is actually there. He went on to find out that this guy might be having certain psychiatric conditions.
no, then we'll leave it.
Want to escalate it to
Correct. That's what he's saying.
Psychiatric expert, and then the person, the patient, is going to be evaluated in person because
No, these are all telemedicine. See, you could be in either Bangalore, the doctor could be sitting in Bombay, to whom you have been referred. You don't know. So that's all. That's why a mobile app is, right. And in worst cases, like you said, probably then he says, okay, why don't you go to Nimans and meet so and so doctor?
Yes.
That could be the last step. But as far as possible, see, the purpose, if you, I don't know, I think you missed the first slide. In the first slide, he mentioned the reason for going for this app. It is because of one stigma in the society where many people hide these qualities, these traits. They don't want to discuss open in the society because they might be stigmatized. So nobody talks. Even if I have a psychiatric problem, I don't talk. I try to hide it. That's one reason. Second reason is in the cities it is increasing. People are now openly coming up and going and meeting the psychiatrists and psychologists and get counseling and try to get treated. They are accepting it now. But in rural India it is still not so high. So to address that gap, this app
I would like to add to what Sir said, sir. So yeah, looking at the mental health service overall, it's evolving at a very huge scale there. So like you mentioned, it's not just one-on-one consultation anymore now. What they're also enabling now is a video consultation aspect for these MHP, Tier 2 sites, not for the Tier 1s there, yeah. Which is why we have the Tier 2 MHPs given the authority to prescribe them medicines also and send them e-prescription via SMS so that they can download and have it in their phone and whatever it is. And if needed, if it's actually needed for this person to visit a one-on-one physical consultation, there are also provisions given in the system that where they can make a referral to a hospital that's nearby to the patient. So we have given some map functionality to these users in their application where they can locate that, okay, they'll ask patient, of course, if they reveal, see, it's all up to the patient if they reveal their location or not. But it's not like we're asking them to locate out their very exact coordinates is all. But yeah, their city, wherever they are staying, so have their hospitals which are nearby to them, we recommend it, and either we recommend it or we directly make a referral from the system to that hospital right away. So that goes as a SMS to the patient's phone that you have been referred to so and so hospital. You can go and have a visit there. That's how it.
I think the importance of this whole application, if you look at it, is more from the usage. See, there is a huge gap in the market, particularly in a country like India, where we are evolving and accepting the fact that mental health is also a disease. It is no more a stigma. It is gradually changing. Unlike advanced countries, European countries, in India it's still not very well accepted, particularly in the rural markets. And there is a huge gap. The demand and supply is, for example, if there are 100 doctors for 1,000 patients as physicians, there could be only 5 psychiatrists for the same 1,000 people. Right? There's a huge gap there. So to address that gap, I think this program was evolved. I think World Health Organization also has supported this, and I think Government of India, the Health Ministry is also in this, and certain other institutions were behind this. And based on certain research, the whole program was.
There has been one very significant finding lately that actually suggests that every 7 out of 10 people that we kind of walk past of is having one or the other psychological condition. Okay. Either they might be suffering from depression or any other things that are actually existing, and they might not be even knowing of it. So
it is changing. It is changing gradually.
Slowly.
Government of India has brought in certain guidelines, particularly, for example, in institutions, schools, colleges. They are insisting that there should be a trained psychologist, a counselor, to address these issues among the student community, particularly people who are appearing those public exams, where there's a tendency to commit suicide. So address these things also there. So I think this is also in the same direction. Good, Amritansh, thanks for the presentation. It was
Thank you.
useful.
Thank you. Thank you so much.
And I'm sure anybody has any other questions?
I have one question.
Please do.
Like, let's suppose I am suffering from 3 years of the depressions and I took a consultation for 3 years and I have some prescription medicines and I am looking into somewhere in the, let's suppose I am talking about the India. India we have one ABA application.
Correct.
So as a customer I am uploading my documents over there. So in the application currently we have some features like we are getting the documents from the ABA like as a past history.
Okay. What documents are you getting from there exactly?
Like prescriptions, reports,
Ah.
all of this.
Okay. So yeah, like I mentioned, one more point I would like to add. Good point you pointed out ABA ID. So yeah, again, like adding to what Sir said here. So government is trying to incorporate every mental health care programs that are there, be it offline or be it online. DMHP one being an example, district mental health program. It's almost present almost at every district. Yeah. But yeah, the doctors there. So yeah, incorporating the doctors who sit there, have them included in this tier 2 program there. And ABA ID is also one such thing where we will be using as a registered ID, which can be used when a counselor or tier 1 professional is entering their consultation details. So yeah, coming back to your question, the records accessibility is only given from these tier 2 professionals. Like I mentioned, and they'll have to go through that consultation from tier 2 right away. Only after getting consulted from them and only after getting a proper prescription from them, a proper certified prescription, that gets SMS that gets sent to the patient's phone number via the SMS, and then they have the PDF with them over the phone that you can download and get the medicines from. So that's one of the key things. I think only the prescription part is where they get the document. That is.
So is it completely anonymous for the tier 1 professionals? Like if I'm calling, if I'm contacting?
I want to keep my information confidential, is what?
Absolutely, absolutely,
It's
yeah.
totally anonymous.
Yeah, it's totally anonymous. Yeah, if you want to read, go ahead. Yeah.
So I do have a question from the business POV. So if I'm contacting their, if I'm calling their toll-free number or whatever the number there is, so I'm talking to a person and I'm halfway through my conversation and the call gets disconnected.
Correct.
So as you said that there are people who are in queue. So the concerned person I was talking to, he or she might be redirected to some other call, and here I am again trying to connect to the same person, and instead I just got the call, like it got connected to some other person. So in that case, how do you manage it? Like again,
Continuity.
otherwise I have to, yeah.
Correct, yeah. So again, that will take some implementation details, but I can have some overview given to this. These are all the validations and all the use cases that we handled when developing this technology, the system there. So if in case a call gets disconnected, it gets recorded in a system that this call was dropped as a call history of that counselor. So we have a knowledge base page given to all of these users where they can see their call history, their callbacks, scheduled callbacks, and other documents that they want to refer to for their own purposes. So in that call history, it gets registered. Yeah, this call that you were taking, it gets disconnected. We have certain icons that show up. Okay, this got disconnected. That missed call icon is there, right? So all those icons we have showing specifically to the user that, yeah, this call got disconnected for so and so reason. And this reason that is being captured is being done by the tier 1 user only, because if it gets disconnected, in the system, they have to enter what was the reason behind the call getting disconnected. Like I mentioned before, they have to capture every detail from call details to the callbacks and to the referrals that they made, and from the EHR perspective. So for call details, they would mention the call got disconnected for so and so reason. That will get embedded in the system as for so and so reason. So after taking the call of the queued person who was next, maybe once they get free, they'll go back to the call history, click on that record which got disconnected before, and then try to reconnect from their end. So they'll basically make an outgoing call to
So
that
they-
patient. Yes. So we have both provisions for incoming calls that come from patient to this toll-free number and outgoing calls from this app system to the.
So I think the other part of her question was not addressed. Okay, she
What was
called,
that?
disconnected.
Yeah.
Even before you are making a call, she again calls and it gets picked up. But the person who picked up could be a different counselor.
Correct.
So will he have access to her past record?
Again, sir.
Yeah.
One second.
Ah.
Does the counselor who picked up the call, who could be the same or a different person,
Hmm.
will he have access to the data that she already shared? She already had a 5-minute conversation,
Correct.
gave a lot of details.
Correct.
So will that new counselor get access to that detail?
Correct.
That's
Yeah.
basically knowledge article.
Absolutely. Yes, sir. So we have that provision also given to them. So for both, so like I mentioned before in this one of the slides where, right, role-based access to the details were limited for tier 1 and tier 2. So the tier 1 details that were being entered were accessible for both tier 2 because just an example there, if you're making a referral from tier 1 to tier 2, the tier 2 doctor would need to know what the consultation was done from this counselor's side, right? So the same way for these, if another counselor picks up the call, they'll have this patient record that's because it's coming from the same phone number. So since that patient already got registered with whatever ID, whatever's there, so we'll have those patient records of all the prior interactions that have been done with that patient there. And this new counselor who has picked up the call, they can see and come back to the consultation
Makes
there
sense.
again. Yes.
When the calls are actually happening, the calls are actually getting recorded or not?
No, calls are not
They are
getting
not
no,
getting recorded.
no.
Are they getting transcribed?
Transcribed,
Because
not.
if it is getting transcribed, then it is easier for the person to get the very context of the entire conversation, even if the conversation is not fully recorded.
But
Then
from
I don't
whatever I
think-
understand that you mentioned, they are recording it. They're probably entering the details manually.
I think that
is very much possible.
I think
Yeah.
call transcription
Probably
is
that could be the next level of this thing. But when he was there earlier, it was all data entry that was being
that was main data entry there. So
And,
we
I
gave
think medical health is more of, even when you go to a doctor, however evolved the system is there, they still write. Okay, there is medical transcription happening, but it's not, even in advanced countries, it's not, they still go and write and then they transfer the data digitally. But otherwise, still it is manually done. Okay, good. Any other question? Okay, thank you. Thank you, Amritansh. I think that
thank
was
you
very
so much.
useful.
Thank you
Thanks for your
everyone.
time
Thank you.
and
Thank you, Kiran
sharing the
sir.
knowledge.
Thank you.